The Injury Response Process, Chapter 1, Therapeutic Modalities by Chad Starkey. The information presented in this chapter corresponds to Chapter 5 in the Therapeutic Modalities, The Art and Science by Kenneth Knight and David Draper. In order to understand how modalities work, we first need to evaluate the body's response to injury. Therapeutic modalities are not utilized to treat specific areas of the body. Rather, we are using them to affect the cells surrounding the injury and to create an optimal environment for healing to take place. Few modalities actually speed up the healing process. The body will heal at its own rate whether interventions are applied or not. Any injury to the body will result in anatomical, physiological, pathological, and psychological changes within the body and its tissues. The basic level of body functions occur at a cellular level. There are different types of cells that occur in the body, and each has a slightly different function. Different cells have different jobs to do. Each cell has a size and shape that is suited for its job. Cells that do the same job combine together to form body tissue, such as muscle, skin, or bone tissue. Groups of different types of cells make up the organs in your body, such as the heart, liver, and lungs. Each organ has its own job to do, but all the organs work together to maintain your body. A group of different organs working together to do a job makes up a system. All the systems in your body are like a member of a team whose job it is to keep you healthy and alive. For the purposes of this course, we will focus on the four major types of tissue found on the human body: epithelial, connective, muscle, and nervous. Epithelial, adipose, muscular, nervous, and connective tissue are the order in which the therapeutic energy must pass to affected tissues that are the focus of the treatment or the target tissue. Each tissue type has a unique property that allows it to reproduce after trauma. The regenerative potential and the ability of each of these tissue types to transmit or absorb various forms of energy must be evaluated when selecting which therapeutic modality is appropriate after injury. Epithelial cells are cells that are very simple, which form the covering of other cells. These cells form the covering layer for all the organs and hence are present in the skin, scalp, respiratory tract, and in the buccal cavity surfaces, for example, skin cells and mucus cells. Mucus lines the body cavities, opening directly to the exterior epithelial layers, for example, in the mouth and nose. The serosus tissue lines cavities that are not open to the exterior, for example, covering the organs. Cutaneous cells form the outer portion of the skin and the integumentary system. Epithelial tissues have the ability to secrete and absorb various substances and have the distinction of being devoid of blood vessels. Epithelial tissues have an excellent potential to regenerate, which is great since this tissue is so superficial and is commonly injured. All therapeutic modalities must pass through the epidermis, dermis, and adipose tissue to reach the affected target tissue. Thermal agents initially heat or cool this layer of tissue. Conduction occurs within the underlying tissue as they lose or gain heat to each other. Ultrasonic energy will pass through the epithelial tissues rather easily. However, due to the lack of water content within these cells, they can create a barrier for electrical modalities. Adipose tissue or fat is an anatomical term for loose connective tissues composed of adipocytes. Its main role is to store energy in the form of fat, although it cushions and insulates the body as well. Adipose tissue has a high water content, which makes it an ideal medium for ultrasound energy to pass through. Adipose also functions as an insulator to protect against heat and cold. The body will want to retain heat within the core, and therefore the effectiveness of heat and cold modalities are highly dependent upon the patient's amount of adipose tissue surrounding the target tissue. Muscle cells are cells that are found in muscle tissue. They're mostly long, large, and have the ability to contract and relax, providing movements. They are of three types, as skeletal, cardiac, and smooth muscle. Cardiac muscle cells are present only in the heart muscle and are responsible for heartbeats. Smooth muscle cells are flexible, yet can contract and relax and are present in the stomach, intestines, blood vessel walls, vascular tissue, as well as other areas, which help in the movement of food throughout the gut. Skeletal muscle cells are attached to long bones and assist in their movement by muscle contraction. Skeletal muscle fibers are classified by the intensity and the duration of the contraction that they can provide. Type 1 muscle fibers are slow to fatigue and are prevalent in postural muscles. Type 2 are fast-twitch muscle fibers that are capable of generating high-velocity forces within a short amount of time. Type 2 fibers are typically found in explosive muscle groups. Muscles are frequently injured in work and sporting type activities. Unfortunately, muscle tissue has a very limited ability to regenerate. Muscle tissues can increase or decrease tissue temperature through conduction with overlying tissues. Exercise is one of the best therapeutic modalities to treat muscle tissue. Electrical modalities may cause muscle contractions by depolarizing motor nerves within the muscle tissue. Nerve cells or nervous tissue. These cells are very long and have many branching ends at either end. Their specialty is that they never multiply in one's lifetime. They are present all over the body and are sometimes as long as a few meters. They are found plentiful within the brain and the spinal cord and form the nervous tissue. Nerves are classified as being in the central or peripheral nervous system. The central nervous system includes the brain and spinal cord. The peripheral nervous system is formed by all the nerves leading to or from the central nervous system. The peripheral nervous system are most frequently damaged during injury or can transmit a signal, which is commonly referred to as pain, to demonstrate to the central nervous system that a damage has occurred. Nerves conduct afferent or efferent impulses via action potentials. Afferent nerve signals are carrying impulses towards the central nervous system, for example, a pain signal from a periphery to the brain or spinal cord. Efferent nerve signals are carrying impulses away from the central structure. Nerves leaving the central nervous system and going out to the muscles on the periphery are efferent nerves. Cells damaged in the central nervous system are not replaced through natural human healing processes and their function becomes lost. Nerve cells damaged in the peripheral nervous system have a limited ability to regenerate. Many therapeutic modalities have some effect on nerve function, usually by influencing the chemical function of the nerves and their potential to depolarize the nerve. In addition, some modalities have the ability to slow or block the pain transmission process of the neurological system within the body. Connective tissue is found abundantly and widely distributed about the human body. Connective cells include bone cells, cartilage, ligament, deep layers of skin, blood cells, and lymph come into this category. They help connect other cells and tissues. It is important to remember certain terminology. Immature cells have names that end in blast. For example, fibroblasts are actively dividing or building up of fibers. Chondroblasts are actively dividing or building up of cartilage cells. And osteoblasts are active division or building up of bone cells. Mature cells have names that end in cyte. Fibrocytes are mature fiber cells. Chondrocytes are mature cartilage cells. And osteocytes are mature bone cells. They are quiescent, which means that they are in a state or period of inactivity or dormancy until an injury occurs. After injury processes occur, depending on the type of tissue, the cell may have an ability to either regenerate or repair themselves. While sometimes these words are used interchangeably, they indicate very different processes within the healing cycle. Repair is fixing the damaged tissues. Unfortunately, the original function or structure is lost, and the repaired tissue is slightly different than the original tissue. This can sometimes happen in muscle injuries. After the muscle tissue is injured, it is repaired with scar tissue, which is much less elastic than the original muscle cells that were damaged. Regeneration, on the other hand, is the formation of the same type of cells and replacing the old or damaged structure and function. This means that the function of the regenerated tissue remains almost the same. An example of this is seen in the skin. When the epidermal layer is disrupted, the regenerative tissue still holds the same or similar elastic type properties as the original tissue that was damaged. Tissues such as nerves and muscles have very little regenerative properties. In contrast, epithelial, blood, and bone tissues have very high regenerative properties. Injuries can be either acute or chronic. Acute injuries typically have a rapid onset, resulting from a macrotraumatic or large force or velocity event. The individual can usually tell you when the injury happened, how it happened, what happened, and why it happened. Upon injury, the physical pain is pretty extreme, as the force or velocity needed to damage tissues is very large. On the other end of the spectrum are chronic injuries. Chronic injuries are slow and have an insidious onset. An insidious onset is an injury or disease that comes on slowly and does not have obvious signs or symptoms at first. The person is not aware of the condition developing. The injury condition is a result of microtraumatic events or many repetitive small injuries. The difficult thing for the patient is trying to explain or describe the onset of the injury, the cause of the injury, or how to prevent the injury progression. Pain for chronic injuries is often dull and achy, but lasts for very long periods of time. It is not uncommon to have depression or depressed sensations with chronic pain conditions. So which one's worse? It depends. The acute injury hurts a lot, but will subside over time. The chronic injury usually isn't as painful at first, but can last for a significant amount of time. Each injury needs to be treated differently. Therefore, taking a thorough patient medical history is imperative to provide the best treatment possible for the patient. The body's reaction to acute injury is divided into two distinct stages, the primary injury and the secondary injury. The primary injury is associated with the tissue destruction directly resulting from the traumatic force occurring during the injury. Primary damage is not reversible. Secondary injury occurs as the result of cell death caused by a blockage of oxygen supply to the injured area or ischemia, or is caused by an enzymatic damage or mitochondrial failure. Cells need oxygen to survive. If oxygen is deprived, then cells die or become necrotic. The use of early therapeutic modalities is often aimed at limiting the amount of secondary injury. Dead or damaged cells release their contents into the area adjacent to the injury site. Therefore, the presence of these chemicals and substances creates an inflammatory reaction from the body's tissues. So, if we look at the picture, say this guy stops in the middle of cutting the tree with a chainsaw. The area that has been cut by the saw is the primary injury. The areas around it are still alive, but will die due to lack of water and nutrients if left untreated. This is referred to as our secondary injury. Ouch! Everyone feels bad when a baby gets hurt or cries, but as we grow up, we're able to handle our pain and injuries in a more mature and controlled manner. However, some people's reaction to injury may still surprise you. As different as the outer response may be for each individual, at a cellular level, we all respond the same way to an acute injury. RICE was an acronym that was commonly used to treat acute injuries. RICE stands for rest, ice, compression, and elevation. A new theory, POLICE, protection, optimal loading, ice, compression, and elevation, has been suggested for the best management of acute injuries. This new theory suggests that prolonged immobilization can often be a detriment during the healing process. Optimal loading is the early implementation of a balanced and incremental loading program where early activity encourages earlier recovery. Once an injury has occurred, the acute inflammatory response mobilizes the body's defense systems and sets the stage for healing. Inflammation has a negative connotation as many people think inflammation is a hindrance and a process that needs to be stopped or avoided. In reality, inflammation is necessary to the healing process. The key to inflammation is controlling and not letting inflammation become chronic. Therapeutic modalities are utilized to help limit the negative effects associated with the inflammatory response during healing. Commonly during acute injury, blood vessels are compromised. For hemorrhage to occur, one of two events must have happened. Number 1, the vessel must be ruptured, or number 2, the vessel must have had an increased permeability so cells and fluids can escape and leak into the extracellular matrix. Primary injury inevitably tears the local blood vessels, resulting in hemorrhage. Blood vessel integrity is damaged, and there will be bleeding. A hemorrhage is rapid bleeding. Ecchymosis is discoloration due to superficial bleeding. A hematoma is deep tissue bleeding. Please don't confuse ecchymosis with a bruise. A bruise is a contusion or internal bleeding caused by blunt trauma. Ecchymosis is discoloration and simply means color changes caused by internal bleeding. Hemostasis is the termination of bleeding by mechanical or chemical means or by coagulation. The body will produce natural hemostatic mechanisms. Natural means no drug induced, no modality used. This occurs naturally. We don't actually have to do anything for this to happen. During primary hemostasis, two events occur which will be discussed in further depth in the following slides: vascular spasm and vasoconstriction, and then platelet plug formation. During secondary hemostasis, two additional events occur: coagulation or clotting, and then a clot retraction. During primary hemostasis, the first phase involves vasoconstriction. This is a constriction or narrowing of the smooth muscle or precapillary arteries. This is the body's attempt to splint and brace itself following injury. This is a reflexive response to the mechanical trauma of injury and is very short-lived. Following vasoconstriction, there is a platelet plug formation. Platelets detect bleeding and attach to the damaged site and line the wall. Platelets cannot attach to each other, therefore they release chemicals such as adenosine diphosphate or ADP, calcium, thromboxane, as well as several other chemicals which increase the stickiness of platelets and allow them to accumulate and get bulky. The increased bulkiness of the platelets results in an accumulation or aggregation of platelets. It is only temporary and is transient. It happens only within the first 1 to 3 minutes of injury. During secondary hemostasis, coagulation is the first step of this process. During coagulation, there is a cascade of enzymes including fibrogen, which is soluble, and fibrin, which is insoluble. These fibers reinforce the platelet plug by forming fibrin threads networks. These networks work in much the same way as a spider web to trap red blood cells, white blood cells, and more platelets. The last phase of the secondary hemostasis is the clot retraction. During the clot retraction, there is a reduction and contraction of the fibrin threads. There is an approximation or closing of the areas surrounding the damaged vascular tissue, which further strengthens the wounded tissue. This is a diagram to review the primary and secondary hemostatic process. We can see in the blood vessel at the top an acute injury has occurred which has damaged the blood vessel. It appears in this picture that the vessel has been ruptured. After injury, primary hemostasis occurs, which is demonstrated by the middle picture. During primary hemostasis, a short-lived vasoconstriction occurs, followed by a platelet plug formation. During the secondary hemostasis process, there is a coagulation of platelets, and then finally clot retraction and wound approximation, allowing for regeneration of the blood vessel's damaged tissue. The rate of healing varies among people, but will always follow the same pattern. Again, using modalities attempts to provide an optimal environment for healing to occur. The goal is to protect the area from further distress and restore normal function at the earliest time possible. At the point where bleeding is controlled, the healing process has already begun, as can be seen on the image on this slide. Each of the phases of healing can overlap with the phase either before or after. These phases of healing are the basic outline for the rest of the lecture. Even though these events can overlap each other and can occur simultaneously, for the purposes of this lecture, we will follow these three stages of the inflammation through the course of their purpose in the healing process as three distinctive phases. It is difficult to examine these phases in an easy order because there is so much overlap. Therefore, I will try to discuss these events as they happen, but to do so, I will have to split up some of the topics. As we begin discussing the three phases of healing, we start with the inflammatory process. We can see the inflammatory process in red. We can see that it overlaps the proliferation and remodeling phase. During the inflammatory phase, we will have platelet accumulation, coagulation, and leukocyte migration. During the proliferative phase, we are going to have repair, new growth tissue, angiogenesis, fibroplasia, wound contraction, and formation of a collagen matrix. At the final phase, we're going to have maturation and remodeling. We will see a resolution of the matrix, permanent tissue depositation, and return to function. There are 5 cardinal or primary signs of inflammation that are often referred to by their Latin names. Inflammation is the body's natural physiological response occurring immediately following injury. In the initial phase of healing, the inflammatory response contains, destroys, and dilutes the injurious agents and attempts to localize the tissue damage. The movement of plasma and leukocytes to the involved area produces the cardinal signs of inflammation. The 5 cardinal signs start with rubor. This is redness that's from an increase in blood flow, increased metabolic rate, and a histamine release. Calor is heat, which is from increased blood flow and an increased metabolic rate. Tumor is swelling, which is the result of leakage of inflammatory mediators into the surrounding tissues. Hemorrhage, high concentration of proteins, gamma globulins, which is an infectious fighting blood protein, and fibrogen, which is a protein present in the blood plasma and is essential for the clotting of blood, that block the venous return mechanism. In chronic conditions, swelling may represent the proliferation of connective tissue. Dolor is pain, which is the result of a mechanical pressure on or chemical irritation of the nerves, or both. This is triggered by the release of chemical irritants, bradykinin, histamine, prostaglandins, and other substances in the inflamed area, and increased tissue pressure caused by swelling or muscle spasms, or both. Functionalisia is the loss of function, which is the result of primary tissue damage or the sum of the preceding signs, or it could also be from muscle guarding. The result of inflammation is the loss of normal function. The magnitude of a patient's inflammation clinically is based upon the amount of swelling, point tenderness, and the loss of joint motion. It is important that inflammation continues until damaged tissues have been removed. It is important to continuously evaluate inflammation in our patients, as this could indicate successful or unsuccessful exercise and modality use during rehabilitation. Again, I can't stress this enough. The inflammatory process is the natural response to injury. These chemical processes and physiological changes occur to immobilize the affected area. They mobilize the body's defense systems and help to contain and control the injured area. Inflammation is initiated by chemical mediators. The extent of inflammation is dependent upon the amount of chemical mediators released. Also, remember that too much inflammation and chronic inflammation are detrimental to the healing process. For example, pitting edema and tendinosis. Continuous evaluation of your patient is important to minimize the risk of developing these chronic inflammatory processes. This is a picture of pitting edema. When they do occur, I would encourage you to send the patient back to their physician for a follow-up evaluation, and in some cases, it may be necessary to increase the amount of inflammation to kick the person out of the inflammatory process. In some cases, physicians have injected saline into an area, or clinicians have applied heat to areas to increase the amount of inflammatory response in the hopes that the body will use this increased irritation and injury to move to the next phase of healing. This obviously should be done with extreme care. The acute inflammatory response is characterized by the release of inflammatory mediators and the migration of fluids and leukocytes from the blood into the extravascular tissues in the affected areas. Inflammation is initiated by chemical mediators that are released from mast cells. Mast cells or mastocytes are large basophilic granules that are found near capillaries. When they become active, they release or degranulate their chemotaxics and activate nearby cells to respond to the trauma, which initiates the inflammatory response to injury. Collectively known as mediators, chemicals are released to control a wide range of cellular and vascular events associated with inflammation. Mediators either perpetuate the inflammatory response, or are known as pro-inflammatory mediators, or inhibit the inflammatory response, anti-inflammatory mediators. These two types of mediators must be balanced to control the rate and duration of the inflammatory response. Some mediators are released by the damaged cells. Other mediators are attracted to the area by chemotaxis. Some mediators cause vasodilation of the blood vessels, increasing the amount of blood, plasma proteins, and phagocytic leukocytes, and the speed at which they are delivered to the area. Other mediators increase vascular permeability, allowing for the movement of blood proteins and blood cells out of the vessels into the surrounding tissues. I would highly encourage you to look at the Starkey text on page 14, box 1-4 for these chemical mediators. Heparin inhibits coagulation by preventing the conversion of prothrombin to thrombin. Histamine is located in the mast cells, basophils, and platelets. The primary function of histamine is to cause vasodilation and increase vascular permeability to increase blood flow to the area. It also attracts leukocytes to the area. Bradykinin or kinins are a group of polypeptides that dilate the arterioles, serve as strong chemotaxics, and produce pain. They are primarily involved in the inflammatory process in the early stages of hemodynamic changes. Once initiated by the Hageman factor, it is the most potent vasodilator and increases vascular permeability. Bradykinins also attract prostaglandins to the injured area. Neutrophils are formed in the bone marrow. Neutrophils are released into the bloodstream and serve as the first line of cellular defense. Neutrophils are aggressive phagocytes that damage both insulting cells and viable, needed cells. Neutrophils follow platelets out of the vessel and are attracted to the injury site by neutrophil and leukotaxin, which are present in the highest numbers within the first 24 hours after injury. Neutrophils are a sign of acute inflammation. Prostaglandins are formed by the cyclooxygenase, or COX. Prostaglandins are responsible for vasodilation and increased vascular permeability. These are synthesized locally in the injured tissue from fatty acids released from damaged cell membranes. Prostaglandins influence the duration and intensity of the inflammatory process. COX is only present in traumatized tissue. PGE1 and 2, the two prostaglandins that affect the inflammatory process. These are responsible for continuing the inflammatory process as long as it needs to be continued for proper healing and may also initiate early repair. PGE1 increases vascular permeability. PGE2 attracts leukocytes to the area. Serotonin causes local vasoconstriction. Leukotrienes are fatty acids that cause smooth muscle contraction, increase vascular permeability, and attract neutrophils. They include slow-reacting substances of anaphylaxis, or SRSA. The extent of these substances' activity is determined by the extent of trauma and results in a correlated amount of swelling. I would highly encourage you to understand and know what these chemical mediators do. It's important to understand the inflammatory response and when each of these is active. Remember, bleeding is still the first response to trauma. This is the sequence of inflammation. The acute inflammatory phase is also known as the reactive or primary phase. It's characteristic of the first 2 to 4 days after injury, although the length of this phase varies. The inflammatory response occurs at 2 levels. 1. Changes in local blood flow or hemodynamic changes, and 2. Changes in cellular function that balances the presence of pro-inflammatory mediators and anti-inflammatory mediators of inflammation. The sequence of events include vasoconstriction, which occurs 10 seconds to 10 minutes by serotonin. Number 2, the release of chemical mediators by mast cells. Number 3, vasodilation and increase in cell permeability. Number 4, margination and diapedesis. And finally, phagocytosis. Vasodilation and increase in cell permeability is initiated by histamine, the kinins, especially bradykinin, and the prostaglandins. During this phase, leukocytes and phagocytic cells are delivered to the area of damage. At the same time, fluids, proteins, and exudate escape into surrounding tissues, which results in swelling from the leaking fluid. Margination and diapedesis are initiated by the leukotrienes. The process of margination is effectively the pavementing of the healing process. It occurs with adhesion of leukocytes to the intersurface of the blood vessel wall. Diapedesis is the movement or passage of leukocytes through intact capillary walls into surrounding body tissues. The last phase of healing is phagocytosis, which is initiated by the neutrophils. Phagocytosis is a process in which leukocytes digest foreign substances and dead tissue. This is a quick review of the acute inflammatory process. Mast cells release mediators such as bradykinin, prostaglandins, histamines, which result in vasodilation. Leukotrienes initiate margination and diapedesis. Neutrophils begin phagocytosis, which is later finished by the macrophages. This whole process takes somewhere between 2 and 4 days to occur. The proliferative or repair phase follows the inflammatory phase of healing. This is the beginning of the second stage. Clearly, there are a ton of events that occur during the injury from 0 seconds to the first 72 hours. The proliferative phase is marked by the removal of debris and temporary repairs of the tissue formed during the inflammation stage and by the development of new permanent replaced tissue. The proliferative phase takes approximately 2 days to 6 weeks to complete. A temporary vascular framework is created and supplies the repairing tissue with oxygen, nutrients, and the cells needed to restore the area. This framework stays in place until the wound contraction phase. The final outcome of the injury response process includes resolution, regeneration, or repair. Resolution occurs when the dead cells and cellular debris are removed, leaving the undamaged tissue by phagocytosis. The tissue is left with its original structure and function intact. Regeneration, the damaged tissue is replaced by cells of the same type. The structure retains some or all of its original structure and function. Repair. The original tissue is replaced with scar tissue. The original structure and function is lost. Fibrogenolysis, angiogenesis, and wound contraction occur at this phase. Fibrogenolysis is the breakdown of a clot. This is the digestion of fibrin threads. At the same time, there is an inactivation of the coagulation factors. Angiogenesis is the new formation of blood vessels. Growth can be slow, several millimeters per day. However, compared to other tissues such as nerves, this can be considered rapid healing process. Following revascularization or angiogenesis, wound contraction decreases the size of the original fibrin clot. Myofibroblasts accumulate at the margin of the wound and begin to move forward towards the center. Fibroblasts produce weak type 3 collagen, making the area vulnerable to tensile forces. Water is drawn into the area of repair and blood vessels, proprioceptive nerves, and sensory nerves begin to develop. When the collagen is laid down, it is done randomly. Early active range of motion exercises can increase the tensile strength of the healing tissue, causing these collagen fibers to align. In superficial wounds, these events form the classic characteristic scar. A scar will always be weaker than the original tissue, which it was replacing. Scar tissue is inelastic and is more similar in structure and function to ligaments and tendons than to muscle. As can be seen in the picture below, wound contraction or approximation of the margin of the wound occurs as the outer margin of the wound moves towards the center, drawing the ends together. Myofibroblasts are strands that pull the margins of the wound inward. During wound contraction, a scar may form. It is important to realize that people will and can scar differently. Hypertrophic scars and keloids should not be confused. A hypertrophic scar is slightly raised, but tends to fill in or heal nicely. A keloid scar, on the other hand, extends beyond the boundaries of a normal scar and forms a nodule or tumor-looking appearance. These are pictures of keloid scars. Keloids are firm, rubbery lesions or shiny, fibrous nodules and can vary in coloring from pink to the color of the patient's flesh or to dark red or even brown in color. A keloid scar is benign and is not contagious, but sometimes can be accompanied by severe itchiness, pain, and changes in texture. In severe cases, it can affect movement of the skin. Most skin injury types can contribute to scarring. This includes burns, acne scars, chickenpox scars, ear piercings, scratches, surgical cuts, or vaccination sites. According to the United States National Center for Biotechnology Information, keloid scarring is common in young people between the ages of 10 and 20. Studies have shown that those with darker complexions are at a higher risk of keloid scarring as a result of skin trauma. They occur in about 15 to 20% of individuals with African, Asian, or Latino ancestry, significantly less in those of a Caucasian background, and there are no reported cases in patients with albinism. Keloids tend to have a genetic component, which means one is more likely to have keloids if one or both of the parents has them. However, no single gene has yet been identified which is a causing factor in keloid scarring, but several susceptibility loci have been discovered, most notably in chromosome 15. The best treatment is prevention in patients with known predisposition. This includes preventing unnecessary trauma or surgery, including ear piercing or elective mole removal whenever possible. Any skin problems in a predisposed individual, such as acne or infection, should be treated as early as possible to minimize areas of inflammation. Surgical excision is currently still the most common treatment for a significant amount of keloid lesions. However, when this is used as a solitary form of treatment, there is a large recurrence rate between 70 and 100%. It has also been known to cause a larger lesion formation upon reoccurrence. While not always successful alone, surgical excision, when combined with other therapies, dramatically decreases the recurrence rate. Examples of these therapies include, but are not limited to, radiation therapy, pressure therapy, and laser ablation. Pressure therapy following surgical excision has shown promising results, especially in keloids of the ear and earlobe. The mechanism of how exactly pressure therapy works is unknown at present, but many patients with keloid scars and lesions have benefited from it. The maturation phase marks the conclusion of the proliferation phase and is characterized by cleaning up the area and increasing the strength of the repaired or replaced tissue. This is the final phase of the injury response and may take anywhere from 3 weeks to several years. This is the significantly longest of the 3 phases of healing. During this process, the number of fibroblasts, myofibroblasts, and macrophages is reduced to the pre-injury level. The scar loses its water concentration, and the scar will typically fade in redness and will be consistent with surrounding skin pigmentation. Collagen cross-linking becomes the main activity. The collagen formation needs to be orderly, not random. If it becomes random, then it becomes a fibrosis and can result in the contracture or adhesion and restrict motion. The proportion of type 1 collagen continues to increase, replacing the existing type 3 collagen, and collagen continues to grow. This strengthens the tissue. As was just previously discussed, the maturation and remodeling phases is the most lengthy phase of the healing process. Tissues take differing amounts of time to be returned to optimal tensile strength, which is very important to returning an athlete to play or practice or returning a patient to activities of daily living or work-related tasks. Ligaments tend to take 40 to 50 weeks for normal tensile strength to return. Tendons are about the same, but only about 85 to 95% of strength is returned after those 40 to 50 weeks. Muscles, anywhere from 6 weeks to 6 months for about 90% of contraction. This is mostly concerning flexion and extension moments, which will never typically regain full pre-injury strength or function. Articular cartilage takes approximately 6 months to have a normal appearance and tensile strength. The tensile strength of bone will occur within 12 weeks for near normal strength and appearance. Wolff's Law has indicated that the body has a certain mechanism to balance the effects of positive and negative stressors. According to Wolff's Law, bone adapts to the forces placed upon it. Bone remodels and adapts to the forces placed upon them by increasing their strength along the lines of the mechanical stress. Most commonly, these stresses are caused by compressive, distractive, or shear forces associated with running, throwing, or other activities. Removal of the stress can also result in bone remodeling itself. If a bone is immobilized, the daily stresses placed upon the bones are remodeled. As a result, the bone adapts to the lack of stress by decreasing bone density. The easiest way to understand this is to use the form follows function saying. With positive stress, we are being helpful, which is the goal of rehab. Negative stress starts the process all over again. As we work with modalities and exercise, we are trying to find that optimal amount of stress that will be positive and will result in optimal changes, but isn't so great that can cause greater injury. These things might be useful to review for the second quiz. For your assistance, I have provided this slide in your Blackboard page as an individual PDF. I would encourage you to read Chapter 1 in the Starkey text or Chapter 5 in the Knight and Draper text. Quiz 2 will be open until Tuesday, September 6th at 9 a.m. You must have the quiz completed to provide verification for readiness to attend Tuesday's lecture class. Please do not forget this quiz or any quiz in the future. This quiz will be over Chapter 1 only in the Starkey text. Remember, this is Chapter 5 in the Knight and Draper text. You will have 10 minutes to complete the 10-point quiz. Please don't get confused. The 4 events of hemostasis include vasoconstriction, platelet plug formation, coagulation, and clot retraction. The 3 phases of healing include the inflammatory, proliferation or repair phase, and the maturation or remodeling phase. The 5 cardinal signs of inflammation include redness, heat, swelling, pain, and loss of function. The 5 events of inflammation include vasoconstriction, the release of chemical mediators, vasodilation and increased cell permeability, margination and diapedesis, and phagocytosis. I would highly encourage you to be able to describe these processes, define your terms, and be able to describe when they happen within the phases of healing.